Hello, I am Kate Nagel, LymeLight's Treatment Grants Coordinator. Welcome to LymeLight Presents, LymeLight Foundation's first ever webinar. Tonight, we'll be featuring Dr. Kinderlehrer and PANS, Tick-Borne Infections as triggers of Pediatric Acute-Onset Neuropsychiatric Syndrome. So first off, we want to emphasize that this webinar is intended to be informational only. It's not intended to provide personal medical advice. Please contact your own personal medical authority for any healthcare related decisions. Additionally, the views expressed by the speaker are their own and may not reflect those of LymeLight Foundation. LymeLight's mission is to provide medical treatment grants to enable children and young adults through age 25 living in the US with Lyme disease to receive proper treatment and medication, as well as raise awareness about Lyme disease. And since our inception in 2011, LymeLight has awarded $9.49 million in treatment grants to 1,339 individuals in 49 states. If you would like to apply for a grant or donate to LymeLight, please see limelightfoundation.org or email us at info@limelightfoundation.org. Tonight, I have the pleasure of introducing Scott Forsgren, LymeLight's board member of over 10 years and a wonderful resource to the Lyme community through his blogs, podcasts, and as a health coach. You can find him through his website, betterhealthguide.com. I highly recommend it. Scott will be introducing our esteemed guest speaker and moderating the question and answer period after the presentation. So now I will turn it over to Scott.
Thanks so much, Kate. Appreciate that. So again, my name is Scott Forsgren, and it has been my honor to be a board member with the LymeLight Foundation for more than a decade and to really see and witness how LymeLight has positively impacted the lives of so many young people recovering from Lyme disease. We're honored to have you here with us tonight for this presentation. Tonight's presentation will be on the topic of PANS, Tick-Borne Infections as triggers of Pediatric Acute-Onset Neuropsychiatric Syndrome. And PANS has really become more and more common in recent years. We believe that it's important to bring awareness to this condition so that children and even potentially adults, as we'll talk about, dealing with PANS can find proper medical care as soon as possible. And many people think of Lyme disease as joint pain, flu-like symptoms, but psychiatric symptoms can really mask the clinical picture. So things like anxiety, depression, OCD, even eating disorders and psychoses are often diagnosed as the primary condition when in fact an underlying infection can be the root cause. So tonight, Dr. Kinderlehrer will present the spectrum of neuropsychiatric illnesses associated with these many infections that we'll talk about. He's going to explain the underlying pathophysiology, explore appropriate diagnostic and treatment strategies as well. And as Kate mentioned, we will have some time for Q&A at the end. So if you have questions, please use the Zoom Q&A feature for any questions that you have. We're not going to use chat for purposes of questions. And we do ask that you keep the questions as general as possible. We won't really be able to go into details of any specific case or provide personal medical advice in this format. And so with that, I'm going to move on to introducing Dr. Kinderlehrer. And so he is coming on there. Dr. Dan Kinderlehrer is a nationally recognized physician with expertise in the fields of nutrition, allergy, environmental medicine, Lyme disease, and healing of the mind, body, spirit as a unified whole. He co-founded the New England Center for Holistic Medicine in Newbury, Massachusetts, and has taught extensively, including practitioner training courses at the Omega Institute, the National Institute of Behavioral Medicine, and the International Lyme and Associated Diseases Society, which many of us will know as ILADS. He created and organized the Lyme Fundamentals course, which is presented annually to practitioners at the ILADS conferences. He's also the author of several review articles published in medical journals and and in the Lyme Times. His popular 2023 book, Recovery from Lyme Disease, The Integrative Medicine Guide to Diagnosing and Treating Tick-Borne Illness, is available on Amazon and wherever books are sold, including through his website at recoveryfromlyme.com. His integrative medical practice is in Denver, Colorado, and focuses on the diagnosis and treatment of tick-borne disease. And again, his talk today is PANS, Tick-Borne Infections as Triggers of Pediatric Acute-Onset Neuropsychiatric Syndrome. It's an honor to have him with us. Thank you for being here, Dr. Kinderlehrer. You may begin.
Thank you. Thank you so much, Scott. And thank you to both you, Scott, and to Kate for the wonderful work you do. I think LymeLight Foundation is a wonderful organization, and I encourage those who are able to contribute because it has helped a lot of people, as Kate described. Okay, I am going to pull up my presentation, and let's see that it works. Okay.
You're all good.
I'm good. I hope we're all good. Okay. So as Scott was mentioning, I think this is a hugely important topic because basically when children or adults present with a psychiatric symptom, typically everything else is ignored and they're treated as simply a person with mental illness. But what if the mental illness is really an organic physical problem manifesting as a psychiatric problem? That's what we're going to be talking about today. Okay, so let's first talk about how big a problem is this? Lyme disease is an epidemic hiding in plain sight. The CDC now reports about 500,000 new cases of Lyme disease every year. However, those 500,000 cases are cases that meet the CDC surveillance criteria, excuse me, which are very restrictive. In fact, there has been a study done. There's been a study where they used the CDC surveillance criteria, which involves a 2-tier laboratory test compared to clinical diagnosis in a doctor's office. And basically 1 to 4, 1 to 5 cases will meet the surveillance criteria. What does that mean? It means that there's another 4 out of 5 who don't meet that criteria. And that means out of those 500,000, we're really talking over 2 million new cases of Lyme disease annually in the US. I'm going to repeat that. Over 2 million new cases of Lyme disease annually in just the United States. Now, it is now well accepted that at least 10 to 20% of these acute cases, these are people who have been diagnosed and have been treated with antibiotics, they become chronically ill. And in some studies, it's actually about 50% of these cases. Okay, they are labeled post-treatment Lyme disease syndrome, an appellation that most of us abhor because it suggests there's something else going on. And to some degree, that's true. We'll get into what that something else is. But those don't include the totally unknown number of people who were never diagnosed with acute Lyme disease and simply became chronically ill. And that chronically ill is maybe neuropsychiatric. They might develop mental health issues. They might develop, severe joint pains, muscle aches, fatigue, et cetera, that, tend to be misdiagnosed. Okay, so the states most endemic for Lyme disease are also the ones with the most moisture. So originally in the Northeast, but guess what? The Southeast, it's quite common. Unfortunately, it's not diagnosed there as much simply because the doctors aren't aware of it as much. Great Lakes area for sure. The Northwest, Oregon, Northern California, Washington. However, Lyme disease is now reported in all 50 states. I say that even though in Colorado, the Department of Health here denies you can get Lyme. I can tell you it's absolutely not true, but somehow they think the ticks stop at the border. Okay, I want to introduce the terminology of Lyme disease complex. I talk about this in the book. It basically, chronic or late stage Lyme disease is not just Lyme disease. It involves infection with specific Borrelia species. So Borrelia burgdorferi is the most common Lyme pathogen in the United States. There are other Borrelia species that can also cause Lyme disease, but I can tell you every one of them, everyone has a co-infection. These are the co-infections. These are the main ones: Babesia, Bartonella, tick-borne relapsing fever, Anaplasma, Rickettsia, Mycoplasma, Powassan virus. Okay, I can tell you that I cannot remember the last time I saw a person with Lyme disease, and this is both acute and late stage, that did not have one or more co-infections. And these co-infections generally are not passive players. In fact, Babesia and Bartonella result in more serious illness and particularly more neuropsychiatric issues, and are more difficult to treat than just Lyme disease. These are really bad actors. So what do we see? We see downstream issues of chronic infection in these chronically ill people and dysregulation of the psychoneuroendocrine immune system. I will come back to that, I promise. Okay, the most common manifestations of Lyme disease complex, this is late stage Lyme, are musculoskeletal and neurological. Although it can affect other systems as well, but that's where the predominant symptoms are. So how do these infections make people sick? Well, acute infection, this is a recent infection, occurs with local invasion of the skin. And depending on what study you look at, there's up to 70% of people get an erythema migrans rash, although only a small subset of them get the actual bullseye, that is with a pale center and one or two or more rings, and that stimulates an immune response. If treated early and adequately, the infection can be eradicated. That's a big if. But you should know that there are studies that show that even at that early stage, there is evidence of these bugs in the bloodstream, not just the skin. So furthermore, eradication is not likely with a short course of antibiotics. A short course is typically 1 week to 3 weeks. That's I should say that I think that the IDSA, the Infectious Disease Society of America, recommends up to 4 weeks. And eradication is not likely with that amount of antibiotics if there's multiple microbes, meaning co-infections, not just Lyme. So what happens with chronic infection, basically chronic persistent infection, what it does is it dysregulates the nervous, immune, and endocrine systems. They're not really separate systems at all. The nervous, immune, and endocrine regulatory systems in our body all work together. You can't really separate them, even though Western medicine does its best to do so. So what do we see? We see inflammation all over the body with a lot of pain syndromes. We see autoimmune syndromes. Autoimmune means our immune system is attacking our own cells, and immune suppression. So we see hyperactivity with autoimmunity, and we see hypoactivity with suppressed immune system. And basically what we're talking about is a software problem, not hardware. We're not looking at lots of invasion of tissues. We're looking at disruption of regulatory systems, which are meant to keep us in homeostasis, but instead chaos. Okay, mental health disorders caused by infections, a really, really big problem. So these are psychiatric conditions associated with Lyme disease complex. And specifically, I'm calling it Lyme disease complex, not Lyme disease, because most of the studies that describe neuropsychiatric Lyme do not screen for co-infections, but that's all we have. So I can tell you that the big three are, let's see, does this work? Yeah. The big three are anxiety disorders, depression, and irritability that can go all the way to rage. Just Google Lyme rage and you'll get a sense of what that looks like if you haven't witnessed it personally. Those are the big three. Those we see so frequently every day. But here's other stuff. OCD, phobias, schizoaffective disorder. That's mainly a combination of schizophrenia and bipolar. And bipolar, eating disorders, alcohol abuse and other addictions, anhedonia, that's a fancy word for inability to feel joy. Dissociative episodes, this is very common. Most of my patients will say, yeah, I just feel like I'm not there at times. I'm just not connected. What's going on around me? Schizophrenia or psychosis, personality disorders, and suicide. very sad statistic. The most common cause of death in people with Lyme disease is suicide. I'm throwing this slide in. I threw it in at the last minute because I just thought it was so important. Bartonella, this is a common co-infection. And I'll just mention that as far as the infectious disease people are concerned, Bartonella is not a Lyme co-infection. It's a vector-borne infection. You know, you get it from cat scratches, fleas, sandflies, and lice, and so on. Guaranteed, it's a major Lyme co-infection. And I can tell you, when I see people with Lyme disease and they have severe neuropsychiatric problems, almost 100% Bartonella is the major actor here. So anxiety, plus and minus panic attacks, depression, OCD, anger, rage, oppositional defiance disorder in children, phobias, substance abuse, personality disorder, psychosis, bipolar, schizophrenia, PANS, obviously we'll be coming back to that, and schizoaffective disorder. Bartonella, I just want to reassure you folks, if you know someone, if you have a child with really significant PANS, really significant mood disorders, out of control problems, I'm willing to bet Bartonella is playing a role. So what is this PANS thing anyway? Well, in 1994, Susan Sweeto, amazing investigator at the National Institutes of Mental Health, described children who developed OCD and tic disorders. OCD, I think you all know, is obsessive compulsive disorder, following a strep infection. Basically, these kids were neuronormative and they were just happy, doing well. They get a strep throat and then fall off a cliff. And 4 years later, she had a whole series of 50 children. And that's when she and her co-investigators coined the term PANDAS, Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infection. Well, it turned out that it's not only strep that can do that, and it's not only children. Sweeto only included kids up to pre-puberty. And so in 2013, the first PANS Consensus Conference codified criteria with a new designation, PANS, for Pediatric Acute-Onset Neuropsychiatric Syndrome. And basically, the major changes between that and PANDAS were that it was not limited to strep. They extended the age range to 18. Now, I can tell you that I have problems with that age range, and Scott actually alluded to it. This is not just children who have this. Okay, what we're talking about is autoimmune encephalitis. We're talking about inflammation of the brain because our own immune system is attacking cells in the brain. So autoimmune inflammation of the brain. That's autoimmune encephalitis. And autoimmune encephalitis can be caused by a number of issues. For example, lupus can cause autoimmune encephalitis, or NMDA receptor antibodies can cause autoimmune encephalitis. The book Brain on Fire was about that condition. But PANS is a subset of autoimmune encephalitis that fits these specific criteria. So these are the case definition criteria for PANS. The abrupt onset of OCD and or restricted eating in a child or adolescent, again, up until 18 years old, no known neurologic disorder to account for the symptoms. You know, they didn't just have head trauma or seizure disorder. And two of the following: anxiety disorder, mood swings or depression, irritability, aggression or rage, behavioral developmental regression. Remember, we're talking about kids who suddenly, you know, lose ability to do things that they used to be able to do. Deterioration in school performance or cognitive problems, motor or sensory abnormalities, such as tics or chorea. Chorea, C-H-O-R-E-A, is a fancy name for involuntary movements. Think of Huntington's chorea, famous because Woody Guthrie had Huntington's chorea. Somatic signs and symptoms, so physical signs and symptoms, enuresis, bedwetting, pain syndrome, urinary frequency, and so on. Okay, this is I think, a really good slide. There's a lot on it, but basically these are the different symptom subsets that we see in kids with PANS. And I'm going to run through it. Some of them we've already seen, like OCD, eating disorders, anxiety syndromes, and depression. But there's some more subtle signs like handwriting deterioration, sleep disorders. We see kids with outright psychosis, and you'll hear about them soon. Irritability, anger, violence. And I'm talking about kids, trying to kill their siblings, serious violence. Cognitive dysfunction, losing their skills in school. Urinary frequency, bedwetting, tics, ADHD-like problems, sensory abnormalities, kids who can't tolerate the feeling of the shirts on their skin, behavioral regression, and choreiform movements. Again, these are the involuntary movements. Okay, so what are some of the microbes that trigger PANS? Well, a lot of viruses. Check it out: herpes simplex, influenza, varicella zoster, which is shingles, Epstein-Barr, HIV, common cold, and SARS-CoV-2 has been documented as triggering PANS. But also mold, mycoplasma pneumonia. I'm going to come back to talk about that one. It's a respiratory pathogen, but can also be tick-borne. Bartonella, which I've already mentioned, streptococcus, and notice I have not mentioned Lyme here because we really haven't documented that Lyme absent a co-infection can trigger PANS. Okay, so I'm going to talk again about what is happening here. And I'm going to first allude to a condition most of us, we don't see anymore, thank God. But I'm thinking of people with rheumatic fever. What is that? Rheumatic fever is when you get a strep infection, as in a strep throat. Antibodies to the strep attack the heart valves. Why do they do that? Because there's a structural similarity between the strep pathogen and the cells in the heart valves. So in a sense, our immune system gets confused because they look alike. And that's called molecular mimicry. So what happens if instead of our antibodies attacking our heart valves, they attack our brain? That is autoimmune encephalitis. So here it is: immune cross-reactivity between microbes and host tissues. Molecular mimicry triggering autoimmune inflammation. In this case, it's in the brain. A really intact, healthy immune system actually puts out a lot of antibodies to these different microbes, but also filter the antibodies so it's not attacking ourselves. But that filter system goes awry in these autoimmune conditions. So it turns out these kids with PANDAS and PANS-like conditions exhibit elevated levels of antineuronal antibodies that attack the brain against dopamine receptors, lysoganglioside, and tubulin. This has been well documented by Madeline Cunningham. And when these antineuronal antibodies, which are not getting filtered, cross the blood-brain barrier, they activate an enzyme, calcium calmodulin dependent protein kinase 2. We affectionately call it CAMK2. What is that? What does CAMK2 do? Well, it mediates many learning, memory, and developmental cell pathways, and it alters dopamine transmission, which is associated with neuropsychiatric disorders and involuntary movements, those choreiform movements. Madeline Cunningham developed the Cunningham panel to assess patients with suspected autoimmune encephalitis. So what is the Cunningham panel? Well, basically, it measures those 4 antibodies that I already mentioned, and it also assesses the activity level of the CAMK2 enzyme. And here's a study. This, I think, was a definitive study. There are other studies out there. This was headed by the primary investigator was Craig Shimasaki. He's the CEO of Molecular Labs, but there was at least a dozen co-investigators. And basically, they started with a big group of patients, but then they narrowed it down to 58 to meet the study inclusion criteria. And these are basically kids who met the case definition criteria of PANDAS or PANS. And they tested them before and after treatment. So of those 58, 34 got better or all better, and 24 did not improve or even worsened. And what they found by measuring the Cunningham panel before and after is a strong positive correlation between the neuropsychiatric symptoms and the antineuronal antibodies and CAMK2 activation. In other words, Cunningham panel was a good test with a sensitivity of 88% and specificity of 83%. So let's introduce some children who developed these problems. Thomas, I met when he was 17. So here was the history. When he was 2, he had fever and lethargy, and he had some routine lab tests. He had very low platelets. Well, this is a condition called ITP for idiopathic thrombocytopenic purpura. And we often don't know what causes it. Could it be a virus, some autoimmune problem? But guess what? Bartonella can do it. And I suspect he got Bartonella at that point because his mother told me after that episode of ITP, he became a quote unquote scary child, violent tantrums. I don't mean just 2-year-old tantrums. I mean like meltdowns, Chernobyl type meltdowns. And somehow by 4 years old, he seemed to get it together without having these violent tantrums. And then he was okay. He was actually good. 12 years old, he's in summer camp in Oregon, and he gets a fever of 104 degrees. They bring him home, and then suddenly, and I mean suddenly, this was abrupt, he had the acute onset of symptoms, starting with severe OCD. Let me tell you how bad his OCD was. His mother told me that he was in the shower for 5 hours, and they had to get the police to remove him from the shower stall. He had severe anxiety symptoms, rage, violence, anorexia. When I met him, his weight was down to 70 pounds. Remember, he was 17 at that point. Psychosis, it was really bizarre. He was defecating all over the place. He was sleeping on the floor. He was refusing to let his parents touch him. I mean, just a lot of bizarre behaviors. Cognitive impairment for sure. Tics, psychosis. I guess he was so psychotic, psychosis twice. Okay, so I've highlighted the really significant antibodies. The strep antibody, anti-DNase antibody, that was done more than once. It was normal. He did have thyroid antibodies, evidence of autoimmune thyroiditis. And I'll just mention that, guess what? Bartonella can cause autoimmune thyroiditis. Glutamic acid decarboxylase antibody, most people know this as the GAD65 antibody. I'll tell you why this is important. This is an antineuronal antibody, but here's why it's important. It's a ticket for IVIG, which is intravenous immune globulin. If you can get an elevated GAD65 antibody, you can get insurance to approve IVIG. We'll come back to that one. He had some low-grade elevations to mycoplasma pneumonia. I actually didn't think that this was significant because they really were low-grade elevations. Lyme immunoblot, IgM, band 41, that's really non-specific, but the IgG had a band 39, which is specific for Lyme. Now remember, I'm seeing this kid 4 years after he got sick, in which he's already lost, I don't know, a third of his body weight. And he's in rough shape, and he's clearly immunosuppressed. So it's not easy getting antibody testing that's positive, but we did. We got a Bartonella antibody that was positive and a Bartonella fish. A fish test is an RNA test. So I'm sure you've heard of DNA tests, particularly in relationship diagnosing COVID. That's a PCR test, right? So this is a RNA test. And that was positive, and it says, yeah, the bug is here. He did test very positive to Babesia, and he also had an antitubulin antibody. Remember, this is part of the Cunningham panel, and he had an elevated CAMK2 activity. And in fact, here is his Cunningham panel. And you can see his antitubulin antibody is elevated and his CAMK2 activity is elevated. This Thomas is a poster child for PANS. And later on, I'm going to be talking about medical gaslighting. And this is a perfect case because basically, despite all his testing, the psychiatrist on the eating disorder unit said, no, I don't think he's got PANS. I mean, he checks off every box for PANS, right? Well, here's the sad story. The sad story is he continued to be psychotic. He's in an eating disorder unit, which is the only place where he's not losing weight because they make him eat. So he slowly gets his weight up into the 80s and so on. And when they feel he's stable, they let him go home, where he totally sabotages his caloric intake. And then he's down to 65 pounds and mandated hospitalization. But the problem is that in the eating disorder unit, they won't give him antibiotics because no, they don't really believe in PANS. They think he's just got anorexia nervosa and he's psychotic. Basically, I'm still in touch with the parents on and off, and as far as you know, he's never been treated. I shouldn't say that. When he was at home for just a few weeks, we started him on antibiotics, which seemed to help. And he is on IVIG, which gives him some temporary relief of his anxiety, but that's it. He's not been on sustained antibiotics, which he needs. Okay, so here's his diagnoses. He clearly has PANS. He's got multiple tick-borne infections, Lyme, Bartonella, Babesia, and Mycoplasma. But I'm just going to mention that as far as the infectious disease people are concerned, Bartonella and Mycoplasma are not tick-borne infections. He's got autoimmune thyroiditis, like we talked about. He's got mast cell activation syndrome, which I'll come back to discuss with another patient. And he had elevated mold toxins in his urine, which is also a common problem in these kids. Okay, let's talk about Lindy. Lindy was 10 years old and she had the sudden onset of feet on fire. Lindy, she was sort of on the border of Maryland and West Virginia. And after having feet on fire, she developed OCD, intrusive thoughts. I tell you a little bit about intrusive thoughts. People, you know, these kids are suddenly thinking they're bad people. They're thinking that maybe their siblings are bad. Maybe they should kill themselves. Maybe they should kill their siblings or their parents. And it can be really psychotic, awful things. Okay, hyperacusis is sound sensitivity. Paresthesias is pins and needles. I can't read that one. It's sort of blocked out here. But rashes, anxiety, phobias, muscle aches, poor sleep, and then panic attacks, irritability, cognitive decline, you know, stop being able to do simple arithmetic, headaches, and hallucinations. Hallucinations is psychosis. Okay. Well, her family doctor did say, I think she's got PANDAS, and tried her on amoxicillin and then ceftonor and then azithromycin, no benefit. And he says, oh, okay, IVIG should do it. And he started her on a full 2 grams per kilogram. She didn't tolerate that. She felt worse. Then when I say worse, I mean a lot worse. So then she's complaining of joint pains and leg pains to the extent where she refused to walk. So now she's in bed or a wheelchair. And abdominal pains and nausea, and she refuses to eat. So she's not taking any oral calories, and they put in a nasogastric tube, and she really doesn't like that. And then they put in a J tube, which is a tube right into the small intestine, try to give her food that way, but that's causing abdominal pain. So then she's put on hyperalimentation, which means she has the central port, and she's getting all her calories and nutrition and substance through this intravenous line that's going through a central vein. Okay, so that's how she was when I first met her. Her laboratory also showed an elevated thyroid antibodies. And again, she has autoimmune thyroiditis, just like Thomas. Her plasma histamine was normal, but she really did have mast cell activation issues, which I'll come back to. She had multiple ASO, which are anti-strep titers. Those were negative, so I don't think she had pandas. But she did test positive for Lyme. She did test positive for Bartonella, and she had very high antibodies to Mycoplasma. So let me talk a little bit about Mycoplasma. Primarily, it's a respiratory pathogen, and most of us have some antibodies to it because it causes everything from colds and ear infections, sore throats, to bronchitis and pneumonia. However, there is evidence that it can also be tick-borne. I can tell you, I and my cohorts who treat Lyme disease see a lot of people with late-stage Lyme disease who also have really significant elevations in antibodies to Mycoplasma. Either it's tick-borne, for which there is some evidence, but not a lot, or there's a dormant infection that's gotten activated by the Lyme. I'm calling it a Lyme co-infection. Other Lyme literate doctors also refer to it as a Lyme co-infection, and it's referred as a Lyme co-infection in the medical literature, but I can also tell you the infectious disease people don't buy it. Here's more laboratory. She tested positive to Babesia, both to Babesia duncani and Babesia microti. Probably did not have two different Babesia species because there is cross-reactivity between the different Babesia. So she could have one and then test positive to the other. She had a Babesia fish, which again is an RNA test saying, yep, here's the bug. She, again, like Thomas, had elevated mycotoxins. She was hospitalized. And by the way, this is right here in Denver, University Hospital, where she has all of these issues that I'm telling you about. They refused to say that she had PANS. They don't believe in PANS. More medical gaslighting, right? She had a spinal tap, which is a lumbar puncture. Her cerebrospinal fluid was normal. And I'm just mentioning that she had two mutations at the MTHFR gene. And this is something I see in most of my patients with PANS. We're not going to get a chance to talk much about methylation. I do refer you to my book where I have a lot of discussion on it, but it's important, and it's something that needs attention, and it's something that's problematic in almost all my patients with PANS. So here is Lindy's Cunningham panel, and you can see significant elevations in the anti-dopamine D1 receptor. You can see elevation anti-tubulin receptor and a borderline elevation in the CAMK2 activity. So here's her diagnosis. She has PANS. She also has polymicrobial tick-borne infections. This is the same. If you look down this list, this is the same as Thomas, the patient that I described before, Lindy, but she really presents very differently. But they have the same pathophysiology: autoimmune thyroiditis, mold toxins, mast cell activation, methylation issues. Well, Lindy, we did get a chance to treat. Once they got her out, we got her out of the hospital and put her on antihistamines. Ketotifen, which is an antihistamine, but it also stabilizes mast cells. Okay, let's talk a bit about mast cell activation syndrome. Basically, mast cells are a primitive white blood cell. So they've been with us from early in human evolution, and they contain almost 200 inflammatory mediators. Some anti-inflammatory, mostly pro-inflammatory. The most famous one is histamine, but there are ones like leukotrienes that are hugely more inflammatory than histamine. So they contain all these mediators, and when they get triggered and release these mediators, then they can cause reactions, inflammatory reactions. So the process is called degranulation. And these reactions can be very obvious allergic reactions, like here's what happens when you get a bee sting, when you get hives, or when you have asthma or anaphylaxis. That's mast cell activation. But it can cause joint pains, headaches, brain fog, fatigue. All sorts of gastrointestinal problems can be mast cell activation. And because she had itching and rashes. We knew she had some inflammation mediated by mast cell degranulation. We put her on these antihistamines, ketotifen and oral cromolyn, which is also a mast cell stabilizer. Her itching and rashes resolved. Great. Number one. Black seed oil, which is also known as Nigella sativa, can decrease neuroinflammation. Some kids have a really good response. I don't think she had that much of a response. Leg pain was a major symptom. Remember, she wouldn't walk. She said her legs hurt and she wouldn't bear weight. Ketamine lozenges, 10 milligrams under the tongue twice a day, much less leg pain. We put her on itraconazole to decrease indwelling mold growth or fungal growth, cholestyramine, which is a toxin binder, and methylation support, which is, we could spend a whole hour talking about that. And we restarted the IVIG, intravenous gamma globulin. But the important thing is we did not start at full dose. We started at a low dose, slowly increased it to the full dose, which for an autoimmune problem is 2 grams per kilogram. She tolerated it well, but frankly, it was really hard to tell how much benefit she derived from the IVIG. We put her on nystatin and antifungal probiotics, and then we started intravenous antibiotics. Intravenous ceftazidime, which is a cephalosporin, not that different from ceftriaxone, mild improvement. Malarone, this is an anti-malarial, which is what we use to treat babesia, mild improvement. And then IV daptomycin. Daptomycin is now accepted as a real good drug against Lyme, but guess what? It also hits Bartonella and it hits mycoplasma. This turned her around. She got so much better. She started eating and we were able to stop the hyperalimentation. She started walking, threw the crutches away, kind of wahoo, no longer needing a wheelchair. And she was happy. I can tell you, this kid was not happy before this. She was quite ornery. Okay, so that's Lindy. Now we're going to talk about Anna, whom I first met when she was 18. But as a child, she had a whole lot of problems. Sensory integration disorder, speech disorder, eye tracking issues, constipation, odd hand movements. Again, this is the choreiform stuff. Facial grimacing, which is tics, and OCD. So she had all these problems as a child. Then as a teen, additional problems, sleep issues, depression, anxiety at night, mania. So let me describe this sleep disorder. Basically, this kid was tired all day. She was just totally exhausted. But somewhere around 11 o'clock at night, she was awake. Not only was she awake, but she was manic. Basically, from midnight until 5 o'clock or so, she was like a hamster on one of those wheels. She couldn't stop. And then by 6 o'clock, she's gone and she just sleeps until 2 p.m. Okay. Migraine headaches, muscle aches, joint pains with knee swelling, nausea, heartburn, sugar cravings, recurrent viral infections, pins and needles, numbness, flushing, hot and cold. And she'd been diagnosed as atypical bipolar. Her physical exam was unremarkable except for dermatographia. Dermatographia is a fancy name for skin writing. That's what it means. I don't know, Latin or Greek. And basically what we're talking about is you scratch yourself. You take your nail and just scratch your forearm on the hairless part. Wait 30 to 60 seconds. Does it turn red or sometimes white with red on either side? And if it does that, it suggests excess histamine and suggests excessive mast cell activation. So she had dermatographia. Her laboratory, her thyroid was low. She had a low morning cortisol. Now, those of you folks who know about adrenal function know that the morning cortisol should be high, and then it goes down during the day so that when you go to bed, it should be on the low side and stay low until about 4 a.m. And that's when it starts to go up. So that's a normal diurnal variation of cortisol. Well, she had already been tested as having a low morning cortisol. And in fact, an endocrinologist had started her on a low dose of hydrocortisone. But when I heard her history, I said, you know, let's see if we can get your cortisol tested at 11 p.m. And sure enough, it was high. It was what her morning cortisol should have been. In other words, she had a reversed cortisol pattern and she was up all night. This is what a cortisol pattern would look like in someone who had a sustained night shift job. Okay, again, urinary mycotoxins, and again, excuse me, 2 MTHFR mutations with a low homocysteine. That's important because usually you associate those mutations with a high homocysteine. So that means she's got additional methylation problems. Again, I go into this in my book, but it's a real detox challenge. Check out her Cunningham panel. Look at the anti-D1 dopamine receptor, 16,000. Really high other antineuronal antibodies and CAMK2 activity. Anna was really inflamed. And here's her diagnosis. So yeah, she's got PANS, there's no question. She's got Lyme disease, Bartonella, Babesia, low thyroid, the reverse cortisol, mast cell activation, the mold issues. She does have bipolar. I mean, that's what she looks like. And you might say, well, it's not primarily psychiatric, it's secondary, but the configuration on the surface is bipolar, and she's got the methylation issues. I've been seeing Anna for years, and we've done a lot, but I would say the one intervention that has made the most difference for Anna has been long-acting bicillin. So those of you who are as old as me, probably not too many of you out there, back in those days in the 50s, maybe into the 60s, I'm not sure, if you had a strep throat, excuse me, if you had a strep throat, you get a shot of penicillin, and that was it. One shot lasted 2 weeks, long-acting bicillin. And there's a neurologist, Dr. Ami Katz in Southern Connecticut, who has had extensive experience with this, and he claims that a really high number of his PANS patients respond to it. My experience is about 50% of my patients respond to it, and we're really not sure why. It's not a very high dose. It's only given once a week for 10 weeks, and she just got dramatically better with that. And I can tell you, Anna, despite all of the issues that she's had, she's in college now, and she's actually doing really well. Okay, we're up to Maddie. Okay. Maddie's one of my favorite people. I met her when she was 14, but her complaints started at 8 years old. Anxiety, panic attacks, and then depression with the dark intrusive thoughts, OCD, agoraphobia, meaning she was afraid to leave the house and rarely did. You know, the first time I saw her was in my office, but I can tell you she was a nervous wreck. Constipation, bedwetting, syncopal episodes, which is passing out, palpitations, sleep disorder, joint pains, drenching night sweats, chest pain, and air hunger. I just want to mention that triad, drenching night sweats, chest pain, and air hunger in a person with a known tick-borne infection like Lyme. That's diagnostic of Babesia. Muscle cramps, fatigue, hyperacusis, which is sound sensitivity, numbness, and tingling. Okay, she knew that she had some food reactions. She knew that dairy caused constipation. She knew that sugar gave her panic attacks, but guess what? She couldn't stop sugar. That is, her cravings were so strong that even though she knew in her head that it would cause a panic attack, she still had sugar. And you'd think that they would just get rid of sugar in the house. That's been a real problem. Okay. Gabapentin did decrease her panic attacks. Mirtazapine, also known as Remeron, that helped her sleep. Fluoxetine, which is Prozac, that made her angry and violent. I just want to mention, you got to be very careful with SSRIs in this group. I have a colleague who sees a ton of PANS patients. She won't touch SSRIs. She says that, you know, that she sees so many bad reactions from them. So if they're going to be used, very careful. They can cause suicidal ideation, particularly in this age group. Okay, so she had POTS, postural orthostatic tachycardia syndrome. What is that? It's just what it sounds like. When she stands up, her heart races. And then what happens is she gets palpitations and she gets lightheaded and she actually would pass out. So this is a form of dysautonomia. I'll talk just a little bit about that. We're talking about abnormalities in the autonomic nervous system. When we talk about the autonomic nervous system, we're really talking about the automatic nervous system. You don't think about your heart rate, how hard your heart should contract. We don't think about where the blood should flow. We don't think about temperature regulation and 1,000 million other issues in the body that our autonomic nervous system takes care of, right? Well, there's two main arms of the autonomic nervous system, the sympathetic arm and the parasympathetic arm. In general, the sympathetic arm is stimulatory and the parasympathetic is calming. It's the reverse as far as the gastrointestinal tract goes. And the whole idea, you got this accelerator and a brake, and the whole idea is to try to keep you in homeostasis. Well, what happens when there's dysregulation of the autonomic nervous system? This is one of the things that can happen. A whole lot of symptoms can happen. And I'll also tell you that we see a ton of autonomic dysreflexia, is another name for it, or dysautonomia, when there's mast cell activation. That's the mast cell activation syndrome and dysautonomia go hand in hand. Thrush, probably mothers out there all know what thrush is. It's basically she had a white coating on her tongue. She also had the dermatographia. When you scratch the skin, left a red line. Prominent stria on the legs, arms, and breasts. Okay, we're going to come back to that one. But she had these lines that sort of looked like stretch marks, but not. And she complained of memory loss. Okay, here we go. She had stria all over. These are the backs of her legs. And believe it or not, doctors are telling her, oh, those are just stretch marks. You and I both know these are not stretch marks. These are from Bartonella, which causes new blood vessel formation. It causes, basically, it stimulates a cytokine called VEGF, or vascular endothelial growth factor, which then causes new blood vessel formation. And when that occurs on the skin or at a level of the dermis, then you get these stria, which are distinct from stria distensae, which is a fancy name for stretch marks. They are in a different level of the dermis. They are on different planes of the skin. And despite the fact that there's more medical gaslighting around this and doctors who say, oh, no, you just have stretch marks. They're not just stretch marks. This doesn't show up quite as well, unfortunately. Obviously, we didn't want to take pictures of her breasts and armpits, which really did show distinct. But here you can see these are not stretch marks, right? Okay, you can actually biopsy these and you'll find Bartonella. Okay, so she had a strongly positive test for Lyme. She had a borderline test for Bartonella, but those stria, as far as I'm concerned, were diagnostic. And then Babesia, she did not test positive for, but she had, remember, she had drenching night sweats. She had air hunger and chest pain. She had Babesia, there's no question in my mind. Okay, she had some hypothyroidism with an elevated TSH. She also had a single MTHFR mutation, again with a low homocysteine, should have been elevated if anything. She also had mycotoxins. We did a test for SIBO because of her gastrointestinal symptoms. That was negative. So I'm not going to spend time talking about it. We did test for strep. That was negative. But here's what I diagnosed her with. I'm specifically PANS-like syndrome because she did not have the abrupt onset of her symptoms according to the case definition criteria. So I'm calling it PANS-like, but definitely autoimmune encephalitis. And this is important. I'm going to drive this home because I have patients who come in here and the parents say, well, we thought our child had PANS, but the doctor said, well, it wasn't the abrupt onset, so they didn't have PANS. That's stupid. I mean, basically the case definition is important because when you're doing studies, in a population of patients, you want to know that that's the same population patients as the next person doing the study, and that they fit certain criteria. But in the doctor's office, let's be smart, yeah? So basically, these kids have autoimmune encephalitis. Okay, polymicrobial tick-borne again. She has Lyme disease. Serologically, that is antibodies strongly positive for Lyme disease. Not so positive for Bartonella babesia, but she had that clinically. She had the POTS, like we talked about it. She had the food sensitivities, which we discussed, probably others besides dairy. And I mentioned yeast, not sugar. When people have sugar cravings and reactions to sugar, usually it's a yeast sensitivity. And remember, she had thrush on her tongue, and she did have some mold toxins also in her urine. She did have mast cell activation. She had the low thyroid and methylation issues. What did we do? Well, we had tried to eliminate dairy, sugar, and yeast. The sugar was a problem. We gave her antifungals, nystatin and clotrimazole. We gave her thyroid replacement, which helped. And in her case, and I wish I could tell you why I chose to do this, and for the life of me, I don't remember, but we put her on disulfiram, and it really helped her. Now, disulfiram, many of you probably know about it. It's also known as antabuse. It's used to treat alcoholics, and I won't go into all of that, except I'll just mention that our friend Scott Forsgren interviewed me, and there's a podcast on disulfiram from that. So there's been a lot of reports on disulfiram, and it clearly is very active against Lyme and babesia and probably Bartonella. It turns out that it also is potentially toxic, particularly when you get to higher doses. And people with Lyme, you have to be very careful with dosing. So we started her on very low, 32.5 milligrams. Just as I say, alcoholics, they were started on 1,000 to 2,000 milligrams back in 1950 when this stuff was approved by the FDA. Now the doses are more like 500 milligrams a day. Lyme, we're starting very low doses. And slowly we increased it to 62.5 milligrams. This is a quarter of a 250 milligram pill. That's it. And she's much better. When I say much better, her physical symptoms were much better. And then we slowly went up to twice a day on that, not all at once, but at 62.5 twice a day, or quarter pill twice a day, she had a significant Herxheimer or die-off reaction, dropped her back to 62.5 and stayed on that. Then we think we're treating the tick-borne infections at that point, right? But we know she has these problems with candida and probably fungi and mold. We tried her on fluconazole. Fluconazole is a systemic anti-yeast agent, also known as diflucan. Well, a low dose, 25 milligrams, twice a week. I mean, people take 200 milligrams a day of this stuff. 25 milligrams twice a week, major Herxheimer reaction. I mean, full-blown panic attacks and so on. We really dialed that down and ended up on 5 milligrams a day was all she could tolerate. In other words, yes, she had tick-borne infections, but the major driver of neuroinflammation at some point became the mold or yeast, which is, of course, a subset of mold. Mold and fungi are synonymous. Okay, we're on to case 5, Danielle. This is a really, really interesting case because it spawned a lot of investigations. So Danielle grew up in upstate New York, which is already, oh my God, territory because there's just so much Lyme there. She had multiple tick bites as a child, but no known problems from the tick bites. However, at 2 years old, it starts with this unaccountable screaming and trichotillomania. I'm sure not many people have heard of that one, but it means hair pulling. And I don't mean tugging on the hair. I mean pulling her hair out. It's akin to OCD, but it's not OCD, but it's sort of put in that same category. Okay, so this is kind of weird, right? At 4 years old, she developed social anxiety, but over time that becomes generalized. She just is anxious and irritable By 12 years old, in addition, she's got fatigue, sore throats, cervical nodes, which are swollen glands in the neck. By the way, in someone with tick-borne infections, sore throats and cervical nodes, usually Bartonella. Okay, so 14 years old, still in upstate New York, has another tick attachment. She has a small rash, like a 2-centimeter rash. No one pays much attention. She's no treatment, but then things get worse. More fatigue, impaired cognition, the postural lightheadedness, right? POTS, sleep problems, and increasing anxiety, depression, and irritability. So more neuropsychiatric symptoms. And then at 15 years old, she basically stops eating. She begins food restriction and purging, but she really does start refusing all food, and she's admitted to an eating disorder unit, and she's suicidal. And she's diagnosed with anorexia nervosa, right? And I'll just repeat something I said earlier, which is that what we're talking about is an organic illness masquerading as a psychiatric one. You know, and once you say, oh yeah, I have these mood issues, boom, you're not going to get a medical workup at that point. You're put in the psychiatric category, and you know, the chances of you getting diagnosed with one of these is only going to happen if your parents stay on your case and work quite hard at it. So she gets put on 2 SSRIs, one at a time, Zoloft and Prozac, and guess what? Makes her more suicidal. Stop that, put her on Abilify. That seems to help her anxiety somewhat. So she goes from inpatient to outpatient eating disorder unit, but she's refusing to eat. So they put in an NG tube. So now she's getting all her nutrition through a nasogastric tube. Basically 5 times she goes from inpatient to outpatient because she's not eating. Each time was suicidal thoughts. They can't get her to eat. At this point, her doctor, her treating physician says to the mother, well, maybe the only thing that's going to happen is she'll lose so much weight that she'll have a near-death experience and decide to live. That was their medical plan. And the mother said, you got to be kidding me. The mother is a nurse, and she's a sharp cookie. And she said, you know, we lived in upstate New York. She had tick attachments. Let's get her tested for Lyme. They did, and they brought her to me. So by the time they brought her to me, she was continuing to refuse all oral intake despite intensive in- and outpatient psychotherapy, psychotropic meds, behavioral interventions. Nothing was making a difference. On examination, she looked pretty good. She had not lost much weight because she was getting calories through the NG tube. She did have POTS, like a patient before her, and she had Bartonella stria. And here's a picture of her stria. And this is really ironic because she thought these stria were stretch marks, and added reason for why she had to restrict her eating. There you go. What a paradox that one was. So she tested positive to Lyme. She had tested positive to Babesia. She tested positive to Mycoplasma. She tested negative to Bartonella. I'll tell you, the routine testing for Bartonella sucks. There are some labs that do a much better job. IGeneX does a better job. I would say that the Bartonella fish test is more sensitive than the antibody test, but you know, it differs from one patient to another. Galaxy Labs does a better job, but your routine Quest and LabCorp and stuff, your chances of getting a positive Bartonella test are very low. Well, here's the good news. Basically, we put her on intravenous antibiotics for a few months and then switched her to oral antibiotics. And after a year, we were able to stop the antibiotics. She's been in total remission for 7 years, and she still is. I mean, she's good. Okay. So here's what happened. Because of this case, I said to a colleague of mine who was sitting in with me, observing, you know, what I do, getting trained. I said, wouldn't it be great if we could go into an eating disorder unit and test a whole lot of people to these infections and see what happens? Well, this colleague of mine said, well, I happen to be the medical director of a residential treatment facility for adolescents with severe psychiatric problems. Basically, all of them have major depression. They do not have eating disorders. They were not equipped to deal with people with eating disorders. That takes specialized stuff. So this is the article I wrote about Danielle. Got lots of good attention. And so here's
10 minutes, Dr. K.
Okay, this is a pilot study. So we took 10 subjects at random and who all were diagnosed with major depressive disorder, 7 with generalized anxiety disorder, none with an organic illness, known organic illness. Basically, 6 out of 10 of them had antibodies to Lyme, Bartonella, or tick-borne relapsing fever. Depending how you interpret the antibodies, 9 out of 10 may have had exposure to tick-borne pathogens. This is in Colorado, mind you. 3 out of 10 positive to strep, and 9 out of 10 had positive Cunningham panels. 9 out of 10 had autoimmune encephalitis. These were kids diagnosed with major depression, couldn't hack it at home, couldn't go to school, and here was the write-up that we did. Okay, so what can we conclude from this? Depression and anxiety in adolescence is often caused by an organic illness, basically microbe-induced autoimmune encephalitis. So I've coined the term PANS. So it's now in a few papers I've written. It's not generally accepted nomenclature, but hopefully over time it will be, because this is not just pediatric and it's not just acute onset. And what do we do for it? Okay, there's 3 main things we do: antibiotics, anti-inflammatory agents, and psychotropic medications. I'm not going to go into detail any of this because I only have probably 8.5 minutes left, but all 3 of these are, well, I shouldn't say psychotropic meds may not be required, but in some kids, they need it. IVIG has been very helpful in some kids. Plasmapheresis is when they take out the blood and filter out the antibodies and put the blood back in. That's helpful in some. There's just a whole lot we can do. But the antibiotics, that's the #1 treatment. Food sensitivity is very, very common in this group. Remember, these kids are inflamed. We're talking about brain inflammation, but their whole bodies are inflamed. And that also means they become sensitized. They become sensitized to mold. They become sensitized to foods. And these are the most common foods that I see as problematic, but it can be anything. These are the most common: gluten, dairy, eggs, and corn. They often have autonomic nervous system issues, mast cell activation syndrome, methylation issues, and they obviously need nutritional support. Okay, so mental health issues in youth are increasing. We know this. It's going nuts, right? I mean, suicide rate is in children and adolescents. It has gone up as the 2nd most common cause of death in adolescents. And I think in 13 years old or something like that is the most common cause of death. So we know there are many psychological stressors, and, and obviously social media and screen time is a big one. Jonathan Haidt just wrote a book about this. But what about organic issues? Autoimmune illnesses are rising. Tick-borne infections have become epidemic. So here's my question: is autoimmune encephalitis an important reason that our children are increasingly anxious, depressed, violent, and suicidal? We have 3 convergent epidemics. We have Lyme disease, meaning tick-borne illness, and there was a study not long ago that said 14.5% of the world population has or has had Lyme disease. Just think of the numbers. Autoimmune conditions. There was a study out of Britain. Now you got National Health Service, right? They looked at 20 million people and 10% were diagnosed with an autoimmune condition. And as we know, mental illness in children and adolescents is climbing seriously. And medical gaslighting, basically doctors telling us things that simply are not true and convincing us that we're crazy. There's a wonderful paper by Jennifer Fagan and her colleagues. I can't recommend this paper enough. And it talks about, here's what happens if you go to a doctor and say, I think I might have Lyme disease. the chances of getting validation, of even getting properly tested, or having your positive test validated as, oh yeah, basically that's a positive test, are low. You have to see, basically end up seeing a doctor like myself, and there's more doctors like myself now. This is a great paper. I highly recommend it. And kudos to the authors. So what can you do? Okay, most important, you got to educate yourself. This is on you. You, the parents, need to get educated. You have to know what this is, and you need to do your homework. And then and once you do that, you got to assemble your treatment protocol with pediatricians, psychiatrists, psychotherapists, and be able to explain it to your children. You're not bad. You think you're bad. I can tell you something that's very interesting about this is, I see the children who go nuts, right? They want to destroy the place. It takes the father to hold them because otherwise they're so violent. And then most of them are so remorseful. They are so down on themselves. This is not psychopathy. These kids are not psychopathic, even though they look like it on the surface when they go nuts like that. They need a lot of compassion. They need a lot of holding, a lot of explanation. So there you are. I want to again thank Kate and Scott for this opportunity. And I think I can stop sharing the PowerPoint.
All right.
And, thank you much for your kind attention.
Thank you so much, Dr. Kinderlehrer. Appreciate that. So we're going to run through some questions here. It looks like we have about 20 questions, and maybe we'll spend about 20 minutes on these questions. So maybe let's talk a little bit about PANS. Some of the cases that you presented today were people or children that were maybe more significantly impaired, but can there be presentations of PANS that are more of a spectrum, maybe not as significant in its presentation, and yet still have a number of the same clinical findings when you start looking deeper into that child's medical condition?
That's a great question. That's a great question. And the answer is yes. Obviously, by the time they reach me, they've been through so much that I hope to think I'm seeing the worst, because I hate to think of kids who are worse than the ones I see. But I do know of kids who really are not as severe, who are not getting significant antimicrobial treatment, who are keeping their acts together and are doing okay. So the answer is yes, they don't have to have as severe a presentation. They may or may not fit the case definition criteria of PANS. Remember those kids diagnosed with major depressive disorder at the residential treatment center right up there in Estes, Colorado. So yeah, there's a full spectrum. It's the same with Lyme and all these infections. Some people are mildly ill, some people are hardly ill at all, some people are bedridden and suicidal.
All right. And just as a reminder, as we get into some of these questions, nothing that we're talking about here is medical advice. So please do talk with your doctor. Question is, my 23-year-old daughter has severe PANS, autoimmune encephalitis triggered by Lyme. IVIG is no longer effective for remission. Next line is recommended for immune suppression, such as Cytoxin. Is this a bad idea with Lyme, even though we're treating Lyme? She's done a few rounds already and is seeing improvement with her cognitive abilities, but I worry about long-term issues.
Wow, that's another great question. So basically some of these kids are getting treated with immune suppressants. I can tell you that Stanford, which is one of the relatively few medical centers that actually recognizes PANS, mainly uses corticosteroids. I mean, they do treat with some antibiotics. They certainly don't recognize Lyme and tick-borne infections. And there are other, rituximide in particular, there are other immunosuppressants that are recommended for these kids. And when the person who asked this question said, well, she's been treated for Lyme and some improvement, but not enough, my next question would be, what about co-infections? I don't see kids or adults. I don't see anyone with significant Lyme that doesn't have co-infections. And if they're really bad, almost always Bartonella is an issue. So before going to an immune suppressant like cyclophosphamide, which in a way they're condemned to for the rest of their lives, I would see a Lyme literate doctor who could do a more generalized investigation into tick-borne illness.
How often do you find patients with severe Lyme complex, someone was listening, Lyme complex induced neuropsychiatric presentation requiring aggressive immunomodulatory treatment like IVIG and plasmapheresis in addition to antimicrobials?
Another good question. So you need to understand that IVIG and plasmapheresis both are very expensive. And that means insurance companies don't like to pay for it and don't like to approve it. And it has a pretty high bar to cross to get that improvement, because IVIG typically is given every 3 weeks, somewhere between $10,000 and $15,000 a pop. So, unless we're Elon Musk or whatever, most of us mere mortals aren't going to be able to do that. And so the issue doesn't come up very much unless we can find another reason for them to get the IVIG. And I'm thinking about not PANS people, but people with neuropsychiatric Lyme disease. And I would say that if we can demonstrate an autoimmune problem, which might include hypogammaglobulinemia, which is low antibodies, that might include CDIP, which is inflammatory neuropathy, and if we can get it approved, we'll use it. That's what I can tell you. If we can get it approved, we'll use it. Plasmapheresis is even harder to get approved.
So I never connected these two, but the question is disulfiram at all similar to naltrexone or LDN? Does it have any immunomodulatory or anti-inflammatory properties similar to LDN?
Another interesting question. The answer is not that I'm aware of. I can tell you initially, Giacomo, at Stanford, who did the initial study on disulfiram, he thought it was anti-inflammatory. My experience is it's not anti-inflammatory. In some people, it's pro-inflammatory. And have to be particularly careful in people with mast cell issues when we're giving them disulfiram. Low-dose naltrexone has gotten a lot of hype. And I don't know why, but I have very poor experience with it. It's just underwhelming. I mean, generally well tolerated, but if you look at it online, it looks like, oh God, this is the answer, and it decreases interleukin-2 and so on and so forth. But I don't see the benefits of it. But what's interesting is full dose naltrexone, in some cases, really helps OCD. There's no big studies on this, but I have seen it work.
So we have a few PANS practitioners on the conversation as well, and one of them said, "Thank you very much for this great presentation. I hope it's okay to share something in case it's at all useful. For my patients, I've found the lack of a raised ASO anti-DNase B strep antibody can't be used to rule out strep or pandas because not all strep strains contain the precise surface proteins to raise those titers. Kind of like antibody testing for Lyme, a positive is a positive, but a negative is a maybe. Additionally, in an acute strep situation, it still takes a good 4 to 6 weeks for the titer to register a rise. Often the health history, family health history, throat and nasal cultures can be more telling in the strep department, just in case that's helpful information. Thank you again so much for all you do." So just a comment there. I don't know, Dr. K, anything you want to comment on that?
No, I'm very grateful for the comment. It's something I was not aware of, and I really appreciate it.
I think this is another practitioner. Have you ever seen anyone recover from PANS that was treated using herbal formulas and probiotics? So maybe broaden that out to say, do all children with PANS require pharmaceutical interventions?
Interesting question. Again, by the time they reach me, they're pretty severe. But I can tell you, I have kids who are without severe neuropsychiatric issues, who do have Lyme, Bartonella, et cetera, who've done quite well on botanical antimicrobials. And I can imagine children with PANS that are not severe might do just fine on those.
There's a question about a 3.5-year-old, and they're considering testing for PANS and PANDAS, possibly congenital. Mom had Lyme while pregnant, had previously tested positive for Bartonella and other co-infections. What would we test for? And are there any doctors in Vancouver, Canada that could help? Our pediatrician does not believe it's PANS or PANDAS because there's no history of strep. So I think in part, go back to the slides that Dr. Kinderlehrer presented. He laid out a number of those labs which your practitioner could potentially order. I know there are some PANS treating practitioners in Vancouver as well. And I think if you just Google PANS in Vancouver, a couple of those will come up. But I think in some of those slides he's outlined, I think that question came in earlier in the presentation. What can be done for a depressed and anxious older teen who cannot manage to be consistent with medications or supplements? This is a good question, I think.
So I presume we're talking about a teen who it's difficulty organizing a structured treatment regimen, but who does have autoimmune encephalitis,
Yep.
I'm presuming.
Yep.
And that would be someone I would consider giving LA bicillin to once every week. That would be something easy to administer. I mean, I wouldn't want to get it, quite frankly, but it's a big shot, and I'm allergic to penicillin. But you know, otherwise, it's I can understand. I can certainly understand the problem, and I don't have an easy answer for it. You know, if the LA bicillin, my experience has a 50% chance of having a significant impact. I think that getting the kid maybe on certain psychotropics, including amphetamines, even if low doses, then that might help him organize his thoughts better, could be helpful. Anything that can decrease neuroinflammation, you know, giving non-steroidal anti-inflammatory drugs on a daily basis can be really helpful. You're just going to have to get creative.
Can self-harm be a symptom of PANS? If yes, in a young adult, what might that look like?
That could look like suicide. I mean, that's how bad it can be, and it happens. It's tragic. I totally understand it, though. I mean, the depression, the agony can be severe. I can tell you that panic attacks, having experienced them myself, it's like the worst thing. It's the worst thing, and you want to die. So
how about head banging? Is that one potential self-harm type symptom?
Yeah, it is. I don't just trying to remember, you know, I can tell you that I see kids who put their fists through the wall,
Yeah.
but not their heads.
Would you yeah, go ahead.
Right, but we know that kids with autistic, you know, spectrum disorders, you know, do have activities like head banging and so on. I haven't had clinical experience with it.
Would you potentially consider cutting as a self-harm behavior in someone with a PANS diagnosis?
I absolutely would. Cutting it, boy, this is a big one. And cutting's associated with obviously other psychiatric conditions, not just PANS, and can be part of a PTSD presentation as well. But yes, I would include cutting with that self-harm.
I believe this is a practitioner question as well. I'm worried about doing plasmapheresis for my patients with suspected or confirmed Lyme disease since I'm concerned it will make them worse. I've seen it do wonders for kids with PANS without suspicion of Lyme or tick-borne illness. At what stage of the Lyme or tick-borne illness is it a good idea to consider plasmapheresis, or am I wrong to be concerned with using this treatment modality with Lyme and tick-borne illnesses?
It's a great question, and I don't have a great answer for it because I don't have that much experience with plasmapheresis. I've had relatively few patients get it, and not through me, it's through the immunologist who's making it happen. And typically these are kids who the IVIG isn't helping, and then we try plasmapheresis. And often, I've seen a study where about 60% of patients with PANS actually did better, but there was also a high relapse rate. And there's a Dr. Morales down in Mexico who really interesting dude. He's really knows his stuff, and I've talked with him. I met him at the last ILATS conference, and I presented a patient to him. Actually, it was Thomas I presented to him, the first patient in the case histories. And I said, I can't get treatment for this kid. What would you do? And he said, I would start off doing plasmapheresis 5 days in a row. And, and I said, wow, that's amazing, because you'd never be able to get that done in the United States. And, I just want to mention that, you can go to countries outside the United States and get more aggressive treatment than you're going to get here. I'm not aware of the problems with plasmapheresis that this practitioner mentions, but I don't have a lot of experience with it either.
Okay, excellent. Let's see here. If your child has Lyme, mold, and histamine issues and PANS, where do you begin? It's hard to know what to do first. And then maybe I'll just broaden the question a little bit and say that it seemed like in almost all of the cases you did find positive urine mycotoxin. So is that correlation, or is that potential or partial causation?
Okay. This is called the art of medicine, right? In a way, nothing I do is evidence-based if we use the criteria of current Western docs who want to see studies where there's only one variable changed. And there's so many variables going on with these kids and with people with Lyme in general that you really can't do a study that's meaningful. So we do it by feel in a way. I try to work on what I would call foundational issues first. Do they have endocrine issues? Looking at the adrenal, the thyroid, the pituitary in particular. And because I feel like that's really foundational. Do they have food sensitivities? And we got to get them on a diet. Do they have gastrointestinal issues? We realize that, the immune system, the nervous system, and endocrine system, there's a huge amount of that going on in our gastrointestinal tract. And so if there's a lot of gastrointestinal symptoms, what can we do to normalize that? And I have a whole chapter on that in my book, because there's a lot of things that can be off there. And basically, doing the foundational work first, and then that would include dealing with mast cell, because there's a lot of stuff we can do for mast cell, but at least it's straightforward in terms of we can give antihistamines, we can give mast cell stabilizers, and so on. And what about the dysautonomia? We can, these are things that we can treat to just try to stabilize this person. And meanwhile, I'll send them also to the psychiatrist. There are a few psychiatrists here in Denver, thank God, who are literate with these kids, and I rely on their expertise in terms of antipsychotics and so on. And when I do start antibiotics, it is careful, really careful. And I usually will treat Lyme first because I consider it low-hanging fruit. It's actually easier to treat than Bartonella and Babesia. And I'll treat Bartonella last because it's usually the major actor. It's the most inflammatory. And if we can get things settled down before going to Bartonella, all the better. So, and then I start on very low doses because you really want to do everything you can to mitigate Herxheimer or die-off reactions because they can cause what? Panic attacks, more suicidal ideation, violence, so we go very slowly, particularly when treating Bartonella. So it's slow. It's one intervention at a time, and making sure that they're stable on one thing before going to the next. And with the antibiotics, moving very slowly, doing everything we can to mitigate Herxheimer reactions.
Any brief comments on whether mold and mycotoxins are more correlation or potentially part of the trigger for PANS?
So this is a great question because I know doctors who say, I don't even try to treat Lyme until we treat with the mold toxins. In some people, that's valid. I've seen it where we just don't make any headway treating the tick-borne infections until we deal with the mold. Now, we do need to get these kids out of a moldy environment. So it does mean mold remediation in the house, and so on. And then it's really an intuitive sense of, am I going to start antifungals first or am I going to start antibiotics first? Now, I should mention nystatin is something that virtually all my kids get because nystatin is an antifungal that is only in the gut. It's not systemic and it's generally well tolerated. But if you're giving fluconazole or itraconazole or voriconazole systemic antifungals, you have to be careful because they can Herx. And depending on the severity of Herx, that tells us something. Now, remember patient 3, I think it was Maddie, 4, I don't remember. But Maddie, the one with all those Bartonella stria, we can't even give her fluconazole in a reasonable dose because she gets a panic attack, just giving her this little dose. The mold is a much bigger problem in her than the tick-borne infections. And that is true. That's true with at least a handful of my patients. So, we go from where the action is carefully. That's all I can say.
There's a few questions on SOT. So what about SOT for Lyme and co-infections? My daughter has had a Lyme SOT so far. What are your opinions of SOT? And then there was another one as well. Your opinions, thoughts, experience with SOT therapy as a Lyme treatment in children with PANS.
It's a great question, and I do not have a good answer. I do not have much clinical experience. The limited clinical experience I have is I have seen some improvement, and I've also seen no improvement. And, and I don't really understand it. I just can't answer the question. I don't have the clinical experience.
How do I find out more about long-acting bicillin? So I think it's also called bicillin LA, and it says, does it work for PANS triggered by Bartonella?
Well, this is so interesting. I'm very friendly with Dr. Katz, the neurologist who loves using LA bicillin. He's a very smart dude in Southern Connecticut. And he has, this is not published, but he presented at ILAD several years ago with over 200 cases of PANS where he used LA bicillin in a large number with positive responses, but we don't know why it works. For example, it's not going to have much activity against Bartonella. Bartonella is mainly intracellular. Bartonella is an extracellular antibiotic. It's a cell wall antibiotic. And the doses are not very high. If we're using LA bicillin to just treat Lyme, in general, we'd be using much higher doses. So is it an immune modulatory agent? And the answer is nothing in the literature that demonstrates that. Maybe it's true. Maybe just no one's ever looked at it. So it's not in the literature because no one's thought to look. We don't know why it works. But I can tell you, I have kids. So I don't remember. Obviously, I changed the names of these kids and I can't remember whose name was who, but the 18-year-old who had the reverse cortisol level. She had Bartonella, she had Lyme, she had Babesia. She did great on LA bicillin. Why? I don't know. I truly don't know. So my impression is, yes, it does help with these kids, and I don't know why.
Several questions on how do we contact Dr. Kinderlehrer to become a patient? Are you currently taking new patients? Can you work with people outside of the state of Colorado via telemedicine? Maybe give us some insights to that.
I was afraid you'd ask that question, Scott. So the answer is no, I'm really not taking new patients at this point. I have been doing occasional one-off consults to get people directed in one direction or another and saying, okay, here's what you're dealing with, maybe 2 appointments, you know, and then trying to refer them to a competent doctor.
If they have a doctor, are you doing any consultations with doctors?
Yes, I am. I'm happy to do what we call sidewalk consultations. Patients will call me asking for medical advice, and of course, I won't just do that. But what I do say is, have your doctor call me. And I put aside some time, and I'm happy. You know, what I want to do more than anything, because believe it or not, I'm getting old, and I want to pass on as much information as I can. That's why I wrote my book. And that's why I keep on writing medical articles and giving talks like this. You know, I really, more than anything, I want to educate, and I'm happy to talk to doctors and render opinions.
What labs do you see as qualified to do good testing? You mentioned Quest. Our doctor had the tests sent there. So maybe we can, you mentioned Moleculera for the Cunningham panel. How about for more of the tick-borne or vector-borne infections? What are your preferred labs?
Sure. My favorite is Igenex. I've been using them for decades. And I'm friendly with Dr. Shah and other people there. And I think they're a great lab. There's a whisper campaign against them at the CDC and so on, and it's all bull. They have very high standards. They've passed all the tests. Galaxy Labs does tick-borne testing, but their specialty is Bartonella. There's Medical Diagnostic Labs in New Jersey that does good testing for tick-borne infections. Those are the ones, they're not the only ones, but I will say that LabCorp and Quest are not going to do a good job. If you can get a positive Lyme test out of them, then the person really got well-documented Lyme. But in terms of co-infections, it's unusual that you'll get a positive test.
So this next question is interesting, and if you're wanting to not respond to the last part, that's fine as well, but I'll put it out there. With IVIG, are there any concerns about contamination with other infections? And then the second part of the question is, do we need to be concerned about IVIG and the potential for spike proteins?
Interesting question. So my understanding from people who have a lot more experience with IVIG than myself is that there are 0 reported cases of people transferring an infection from an infusion. And this spike protein that's really interesting. We think that these people with long COVID have autoimmune problems, not dissimilar from Lyme and tick-borne infections. In fact, they often look the same as people with late-stage Lyme disease, but that it's not that the virus is still there intact, but that the spike protein is, and that's what's triggering the autoimmune problems. So is it conceivable that that could be in the IVIG infusion? And my understanding of IVIG is that it's mainly just antibodies, that they've taken out other proteins. So I wouldn't think that the spike protein could be a contaminant. That's my understanding.
If a child can get better from PANS, can some of their cognitive abilities recover? And generally, how long does it take to treat PANS? I know that's a hard question, but what are your thoughts?
So in terms of cognitive capacities, absolutely. I was talking with she's in her 20s now, and she doesn't, her sister has full out PANS and is doing so well. She's in college now. But she's got a PANS-like syndrome, let's call it that. And she's talking about how bad her memory is. And she's really worried about it. Like, is this it? Am I going to have dementia? You know, she loses track of what she's saying mid-sentence and so on. And I was remembering when I was really sick with Lyme. Okay, so here's how long ago this was. We had answering machines, not voicemail, okay? And so you take a message off the answering machine, and person would say, it would give their number, you know, please call me back at. I could only remember one number at a time. I would have to go back 7 times to get the phone number because I couldn't keep 3, 4, let alone 7 numbers in my head at a time. And I'm good with numbers. I actually have had a great memory. I don't know if I do now, but the answer is yes, absolutely. I know someone before I had Lyme, and I really didn't know much about Lyme. A remarkable woman brought her kids to me who were diagnosed as being psychotic and had been put in mental institutions, and the daughter's IQ had dropped 50 points. And once she was treated, she was normal. She went to college. Yes, they can recover.
Not a question, just a huge thank you for all of this. This has been so informative and helpful. We are so blessed that Dr. Kinderlehrer is working with us about our son's condition. His Cunningham panel is of 4 out of 5 markers in the red. We searched for years trying to figure out what he's struggling with, including psychosis and suicide attempts. So many pieces of the puzzle are coming together now. We are cautiously optimistic that maybe we can find treatments that will help him. Thank you. I got chills with that one. So thank you, Dr. Kinderlehrer, for that amazing support you're providing there. I think we're about to wrap up. We're not going to get, the questions are actually coming in faster than we're answering them. There is a question, do you see a role for parasites in neuropsychiatric conditions? And also, do you think that ketamine will be prescribed more often in the future?
Okay. So I have this kid, this patient, this child. I'm thinking he's about 10 years old. And a couple things, I'm trying to distinguish him and his brother because they came at the same time. But the kid had parasites, and I test patients for parasites a lot. I'll just mention that I actually believe most of us have parasites. This is something that some integrative medicine docs say, and I've come to believe it. But I think for most of us who are otherwise healthy, these parasites are just part of our flora, along with the trillions of other microbes that we coexist with. But when our immune system goes awry and we start reacting to everything and under the sun, then we start reacting to these parasites. And I'm not talking about just GI symptoms. I'm talking about migraine headaches and joint pains and fatigue and so on. And this 10-year-old kid basically would go nuts every new moon. And in fact, what we did was we treated him with antiparasitics, and he wouldn't go nuts every new moon. And over time, he stopped going nuts and didn't need the antiparasitics. I think it was his brother who, when I first saw him and I asked him about his diet, the parents were really careful, and they said, well, he's off sugar, he's off of gluten and dairy and so on. And I said, does he crave anything? This is important. Does he crave anything? Well, he'll eat a whole jar of pickles or olives. And I said, that's fermented. It's yeast. He's craving yeast. He's not getting it in bread and so on. That's where he's getting it. And you need to take it out of his diet. And so this is important. It's called the allergy addiction syndrome. It's very important. The food you crave could be the reason why you're feeling terrible. And you take that out of your diet and then you feel worse. You go through withdrawal. And with kids, the withdrawal usually lasts less than a week, but with adults, it can last 2 weeks. And then you feel much better. Well, that's exactly what happened with this kid. The kid normalized. He stopped being belligerent and obnoxious, and it was a nice kid. And then he went worse again. What happened? They put corn back in his diet. But the crazy thing, it's like we're sitting like, well, what happened? What changed? And they said, well, we let him have some corn chips. And he goes, don't take away my corn chips. Okay, corn's the problem. Take out the corn. And he's not the only one with corn problems. I have a patient with PANS right now. Corn. He has corn. He crashes. He stops eating. Everything goes south. So yeah, food sensitivities can be a big deal, and particularly be aware that food cravings can mean food sensitivity.
And then the second part of that question was, do you see ketamine being prescribed more commonly in the future?
Absolutely. I see ketamine being prescribed more commonly, but this is a big but. My patients don't tolerate ketamine like the average population. I'm good friends with a neurosurgeon here who you probably know, Scott. And I said, are you using ketamine much to treat neuropathy? He said, oh yeah, it's like my first line. How much are you using? Oh, 50 to 100 milligrams 3 times a day. And I'm like, really? Now, he's treating NFL players, NBA players, he's treating people that are over 300 pounds. I've put people on 25 milligrams or less, adults, and they don't tolerate it. And then there are some people who do well. The bottom line is it's worth trying. It's not good for anxiety, but it is good for depression in some people, and it's good for pain, neuropathic pain in some people. But these people who are inflamed start with a low dose.
So my last question for you is, we've talked about a lot of serious issues that these kids are dealing with. There's a lot of parents on that their children are going through this now. First part of the question is, are there some resources, PANS, PANDAS support type organizations where people can learn more, but also potentially connect with doctors? And then the second part of the question is, what can you say to give parents hope that their children have the potential to recover?
These are good questions you're asking.
Thanks.
Okay. There are organizations. The one that I'm most aware of is Aspire, ASPIRE. That's an acronym, although for the life of me, I don't remember what it stands for, but it's a great name. And it's all about PANS. Go on their website and you'll see a ton of lectures. I've lectured there. Susan Sweeto's lectured there, I think, more than once. I mean, just everyone you can think of. It's a who's who of doctors who treat PANS. I highly recommend that. And it is incumbent. It's incumbent on the parents to educate themselves, because it's sad, because most doctors are not educated. What we're dealing with right now in terms of tick-borne infections and PANS is medical gaslighting on steroids, because both conditions are denied by a big part of the medical profession. It's tragic and insane. I've patients whose parents who say, yeah, my pediatrician says he doesn't believe in PANS. And I'm like, whoa, I didn't know this was a faith-based problem. I thought it was science. Seriously. There's so much bias, and it takes so long to turn heads around. I could go on and on about this, but other than Aspire, I'm sure there are other organizations out there, but I don't know them. And there was a second part to that
Yeah,
question.
what can you say to give parents hope that their children have the potential to recover?
So far, with the exception of Thomas, the first patient, who never got treated, I think that these people get better, but it takes stick-to-itiveness. You know, I'm treating right now a 17-year-old kid in North Carolina. And, you know, nothing's working, and, you know, and the poor kid is just so depressed and so anxious and so irritable. And he's just this bright, lovely person who's so miserable. And so now he's on a low dose of methylene blue to treat his Bartonella. He's starting to smile. I mean, it's like a wonderful thing. I mean, it just, you just can't give up. You can't give up. And you just got to keep trying things. And there are things more aggressive than what I mentioned. You know, one of the questions talked about cyclophosphamide. The only good news I can say about that is they're taking it seriously. The doctors are recognizing there's a real problem here, and it's an inflammatory problem. Like I said, rituximab is used more often, but we are talking about serious immunosuppressants and problems with that. And, you know, but we got to use everything we can, and patients get better. You know, everyone except Thomas got better. I have patients who are worse than some of these people that I described today. They're
Wow.
better.
I would like to thank Dr. Kinderlehrer for this amazing presentation and for all the work that he does. And I would remind you to check out his book. It's amazing. I learned a lot from reading it myself when it first came out. You can learn more about him at his website as well at recoveryfromlyme.com. So thank you, Dr. Kinderlehrer, from the bottom of my heart, and everyone that's joining us today. You really do make a positive difference, and we so appreciate you. All right, Kate, you want to jump to the next slide? Just as a reminder, LymeLight Foundation provides medical treatment grants to children and young adults through age 25 living in the U.S. and dealing with Lyme disease. So to apply for a grant or to support our mission, please visit LymeLightFoundation.org. Lastly, I want to thank Kate and Katie. They've done a lot of background work to make this happen, to make it look professional, just to pull everything together, to put it out on social media. This would not have happened without their support. So thanks to Kate and Katie and the entire LymeLight team for making this event possible. We do welcome any feedback. This is our first LymeLight Presents, and so would love to hear your thoughts. Please reach out to us. The email address was provided earlier, info@LymeLightFoundation.org. We would welcome your thoughts, and if this is a format that's interesting to you, if you'd like to see more in a series of LymeLight Presents, we would love to hear from you, and then we can explore how to make that happen. So thank you everyone for being here tonight. It was a very informative conversation. We appreciate your wonderful questions. We hope you found the webinar informative, and we really wish you well on your continued healing journeys. So thank you again for being here, and good night, everyone.